Hi, Dr. Salari. How are
Don,
you?
it's great to see you.
Always great to see you. And
Absolutely.
I know that all my clients that I send to you think highly of you, and you have an impeccable reputation in
You're too
town.
kind, sir. I appreciate that. Thank
And
you.
and so I've got a client that I want to send to you with a pretty severe lumbar problem.
Yes, sir.
And could you give me some tips as to what you would do? Because I'm going to send that person to you, but I just wanted to know what to
Absolutely.
expect.
And does that patient have any symptoms associated with one leg or another,
Yes,
or?
he bilateral radiculopathy or leg pain. So
I see. Okay. Yeah, in general, I like to see the patient in person to be able to evaluate them, get a good history from them. I'd like to bring them in so that I can examine the patient, get a idea of where their pain may be coming from just based on the physical exam, and then from there we evaluate them based on any imaging studies they either may come with or any imaging studies that we might want to order to determine kind of where the symptoms might be coming from. A lot of times we try to not necessarily order too many imaging studies if we don't have to, if they just come in with mostly back pain, but it seems like in this case your patient has at least some symptoms going down into the lower extremity. You said that they have radiculopathy, radicular symptoms. That just really means that they have at least some origin of pain from here that's radiating or shooting down into one leg or maybe the other leg or both legs in this case.
and you can tell where the pain goes down in either leg, what disc level it is, can't you?
Oh, absolutely. Just based on doing the exam, for example, I can tell whether or not it's at the lowest level of the disc space or the level above it based on, again, where the pattern is. If it's a pattern that radiates into the front of the thigh and mostly into the knee, or if it's mostly into the shin area or on the top of the foot, the bottom of the foot, all those give me some clue as to where some of that pain may be generated from. So from there, basically, if they do come in, and a lot of times, a lot of the patients that you send me have the whole entire package of imaging studies available to them, and so when they come to see me, I'm able to evaluate them pretty closely. I can look at that MRI scan, for example, that they come in with and determine where some of that pathology could be coming from. Typically, it's the L4-5 or maybe in the L5-S1 disc space, and so based on where that pathology is, we can then further determine the course of action, how to treat that patient. We try to maximize conservative care as much as possible, and if surgery becomes an option, then we can always talk to them about that as well.
When you do surgery on a lumbar spine, can you usually go in posteriorly, or do you have to go in from the front?
Sure. Um, the one thing that affords the lumbar spine that may not afford necessarily the other portions of the spine is that you can access the spine through the front, you can access it through the side, you can certainly access it to either the back as well. And so gaining access to the spine is not an issue. It's trying to determine the best course of action for that particular patient and where the pathology is and how you can best treat them based on some of the other factors that may play a role. If they have a lot of abdominal issues or have had surgeries in the abdominal wall, for example, an approach to the front of the spine is not necessarily the best approach to take.
It's very complicated, isn't it, when you
It
go
can be
through the
very
front?
complicated when you go through the front, correct.
Right,
And
right.
so a lot of times you can do most of everything that you need to do all through the back of the spine as well.
Good. And when you do a fusion, is that usually 2 levels, 3 levels, or even 1 level, depending on the problem?
Sure. I think a lot of times less is more in those situations. You certainly want to only operate on the level that has the pathology. Now, obviously, if they have a lot of alignment issues and you have to correct certain alignments and that has to be something that you have to be corrected, then multiple levels would be necessarily involved. But if you can isolate the pain generator to a single level, then you can hopefully address that accordingly. And fusion is not always the first option. We try everything else to avoid the fusion. If fusion then becomes an option, that's typically our last option that we discuss with the patient.
Okay, yeah, I know you're really careful about that,
Mm-hmm.
and they all like that. So that's good. When you have a situation where the patient has osteoarthritis or arthritis in the lower back, what do you
Mm-hmm.
do with that usually?
Uh, and hopefully that's the only issue that they have and they don't have the symptoms going down the lower extremities. I try to really maximize conservative care where we try to build up a lot of the muscular structures that are in and around the spine to help at least with the dynamic control of the spine itself. And then we tend to refer to our pain management colleagues in town who can then provide injections to certain spots that could hopefully reduce the inflammation associated with that arthritis. We try to evaluate the patients and see whether any of that arthritis was exacerbated by the injury that they incurred. And so really try to do a very thorough examination of all available studies to be able to determine that.
And an MRI can show whether the findings are acute or chronic, acute being happening within the last 6 months and chronic over 6 months. Is that correct?
Yeah, absolutely. So an MRI scan should definitely at least give you some idea as to whether or not there's some level of acuity to what's just happened. So again, as you said, acute meaning it just has happened or it just kind of came about. You can definitely tell whether there's any inflammation in the bone structures within either the joints that are in the back, or there's a lot of inflammation in the end plates of the bone structures, or even if there's any microfractures or something like that.
And when you do conservative cure, you do physical therapy, do you do ESIs, epidural steroid injections too?
We try to maximize everything. We try to get them into a nice routine with the physical therapist where we try to, again, build up the core musculature and also any form of myofascial releases, whatever the physical therapist does think is the right thing to do in that regard. And then, yes, we certainly try to also offer them less invasive means of addressing their pain. And so a lot of times an epidural steroid injection, that's an injection of cortisone, for example, seems a feasible means and matter to address their symptoms.
Sometimes you would do an RFA, right? And what is an RFA?
Sure. An RFA is a radiofrequency ablation, and a lot of times that's utilized in a setting where a lot of the pain is generated from the facet joint complex in the back. And the goal and the aim of the RFA is to at least deaden some of the nerve structures that provide the sensation to that particular joint. And so that is an option, and typically again, most of our pain management colleagues in town are very well versed in doing some of those procedures.
And radiofrequency ablations generally do help, don't they? Unless it's a real severe problem.
There's definitely good information and good studies in that regard showing that there's at least some level of response to that form of treatment. Absolutely.
And I know when you do surgery here at your facility, you have the facilities to keep them overnight, correct?
Absolutely. We, again, try to do the minimal amount of surgery that's necessary for the patient. I try to, again, offer them decompressive type surgeries, a laminectomy procedure of some sorts to, again, if it's mostly something where the nerve is involved, then I would have to basically just take the pressure off the nerve. But if it does have to come to something that's a little bit more involved, like a fusion procedure, we still have the ability to offer that to them at the surgical center that we have here. And also, if they need to stay overnight with us, we have the ability to offer that.
Thank you very much.
Of course.
Good seeing you again.
Good to see you as well.